Many of you are familiar with NTAC, but some in the audience won't be. It's the National TB Advisory Committee. It's made up of jurisdictional members, so representatives of each state and territory in Australia who are involved in TB control. It also has a number of expert members covering the areas of paediatric TB, a regional engagement specialist, and so on. So this group comes together, and we have 2 face-to-face meetings each year, interspersed with teleconferences, and we try and set policy and guidance for TB control in Australia. So, a landmark era in TB control in Australia was the National TB campaign from the post-war period, 1948 to 1976. And this was a period of population-wide active case finding using mass mini X-ray screening, contact tracing, a BCG program in our schools, and new drugs. And I said eventually because a lot of the decline in TB incidence occurred before the introduction of, say, rifampicin and pyrazinamide into conventional therapy. So this is a graphical representation of notification rates over that period since 1948, and you can see that there was about an 80% reduction in TB incidence between the late 40s and the mid 70s, and this equated to about an 8 to 9% decrease per annum. However, for the last 30 years, our rates have remained fairly stable, although very low, in between 5 and 6 per 100,000. Now, who gets TB in Australia? Those that are regularly reading our NTAC annual reports will have seen various versions of this graph, but there are maybe some researchers in the room from out of Australia who haven't seen this before. The blue bars are in overseas-born people living in Australia, and they account for 86 to 89%, depending on the year, but almost 90% of TB notifications are in the overseas-born. The red bars, the little tiny red bars down the bottom, are Aboriginal and Torres Strait Islander people with TB, and the numbers of cases are very small. But if you look at the dotted red line, that's the rate, it's significantly higher than in non-Indigenous Australian-born, 6 to 7 times. The number of cases, again, in the Australian-born is low, but the rate is actually sitting below 1 per 100,000, and that's actually, in broad terms, the WHO targets for pre-elimination by 2035. So in that, for 70% of the Australian population, we've actually got to that 2035 target. But that's not the whole population. And just another point on migrant TB is that, like many countries, we have a process for detection of TB in visa applicants in an offshore setting. And this program does detect a reasonable number of TB cases. When you consider that we have about 12 to 1,300 notifications for the whole country per year, we're getting about a third of that again as being detected as cases offshore. If you look at 2014, the top countries where TB was detected in visa applicants: Philippines, Vietnam and China. Interestingly, the rates of MDR-TB in that cohort was relatively high at 8.5%, and there was 2 cases of XDR that was detected by the screening program. And of these visa applicants, almost 70% were for temporary visas, and half of those were for student visas. So I think it's just important to just touch a little bit on the burden of TB in our migrant population and those who've come from other countries, to look at how we might approach it in a strategic sense. So at this point, I think we can say that Australia has had great success in TB control to date, that the incidence rates on a global scale are low but stable, that we are detecting active TB, not latent TB, but active TB in visa applicants in an offshore setting, and then they're treated and then can reapply for their visa. And given this, that most of our cases are in the overseas born, we're unlikely to really reduce rates further unless we actually address latent tuberculosis, unless we embrace and encourage and enable the development of new strategies and tools, and unless we have meaningful engagement with our region. In 2014, the World Health Assembly ratified the WHO post-2015 plan for TB control, and this was called the NTB strategy. And this was a strategy that called on hitting pre-elimination targets that are defined here on the slide by 2035, with the aim of elimination, so less than one case per million, by 2050. Now, the table here is from the NTB strategy and highlights three particular areas. One is a target of reduction in TB deaths. Second is reduction in overall incidence. And thirdly, that no family should face catastrophic costs as a result of TB in that family group. And by 2035, they were aiming for a 90% reduction in mortality and 80% reduction in incidence. And right from the get-go, by 2020, no families in catastrophic financial hardship. Again, a commonly shown graphic. If we were to continue at the current global trend, which at least is a decrease in incidence rather than an increase, it would take, perhaps not forever, but perhaps forever, to eliminate TB. Even optimising our current tools and methods and strategies, the best we think we could hope for will be a 10% reduction. And it's really the introduction of new vaccines, diagnostics, treatments both for active TB and latent TB, which will kickstart a meaningful reduction to be able to hit those targets. Now, not all countries are the same, so the WHO further developed a plan for low incidence countries like Australia. And this was a TB elimination plan which highlighted 8 priority action areas. And I'll come back to that to discuss our own plan. So the first thing about a national strategic plan for anything is who is it for? And in this context, there was a lot of discussion amongst NTAC members. Was this a plan for NTAC, something that NTAC members could do? After all, we're an advisory group. We're not really, we have operational capacity through each of our jurisdictions, but we're otherwise an advisory group to the CDNA and henceforth to the Commonwealth Government. So we took the view that we couldn't do everything, but we will develop our own work plan on the things that we can do. But we thought this was a collective view of what we think needs to be undertaken in very broad terms for TB control in Australia, and to place Australia in a position where pre-elimination targets can be feasibly met by 2035. We also emphasise in the plan, this is not just about health. This is about other agencies such as, I had to change the slide, I used to say DIBP, but it now says Home Affairs, Foreign Affairs and Trade, and as well as other agencies. And we also saw the opportunity as our strategic plan will eventually be published in Communicable Disease Intelligence and be available on the internet. This is an opportunity to tell our regional neighbours, international health agencies and others, researchers, what the epidemiology of TB in Australia, what are our successes today, what are the challenges, and how are we going to approach them. So the strategic plan this time is, to borrow a WHO word, ambitiously entitled, the Strategic Plan for Control of Tuberculosis in Australia 2016 to 20 towards disease elimination, because that's where we want to take the focus. Now this is a table of contents. The first half is really informative. It's about where we've been, how we organise ourselves, a little bit about the laboratory network, and a bit about the governance of TB control in Australia. We also touch upon some of the output from the last strategic plan of 2011 to 2015, and introduce the new one. And then the second half of the document is aligned word for word with the 8 priority action areas as outlined in the TB elimination plan for low incidence countries. I'm going to go through those 8 priority areas. It's a little dry, but I think it'll hopefully I'll be leaving time for discussion, because I think it's the discussion afterwards which is perhaps more important. At the moment, it's difficult for anyone to source this plan because although it's approved and can be circulated, it's not actually published. So priority 1 is to ensure political commitment, funding and stewardship for planning and essential services of high quality. The action points that are in italics are the ones that we've highlighted in the executive summary as being perhaps of additional significance or importance. So we believe there should be a national and jurisdictional assessment of the regulatory and structural requirements and a cost analysis of what's required to implement the plan. So it's a fairly big one for number 1. In broad terms, we need to identify funding to implement programs towards elimination of TB. In Warwick's preamble, he mentioned newer and younger people working in TB research and diagnosis. And we certainly see that this is a very important thing, is to develop and maintain a dedicated, skilled workforce. And to engage in bilateral, in fact multilateral political engagement in the area, South Pacific region, in relation to TB control. The little quotations in red on the side, you can read, I won't read those out, but the little quotes that I've picked out of the strategic plan, which I think give a message. Priority area 2 is to address the most vulnerable and hard to reach groups. Although the cases in Aboriginal and Torres Strait Islander Australians are low in number, the rate has for many years been discrepant, and can we not do something about that? So we feel that there needs to be engagement with representatives of Aboriginal and Torres Strait Islander communities to identify key challenges in their communities and do something about them in a culturally appropriate way. We want to review the current collection of TB risk factor data, and in fact many of you may be involved in a study coordinated through ACNet and Pioneer, the chief investigator being Kerry Viney, looking at it in much more detail about risk assessment of patients with TB in Australia. We encourage the use of new tools for improving collection of information on at-risk groups, and these can be things like geospatial mapping and other technologies which might help understand our at-risk and vulnerable groups better. And of course we do support the WHO in removing financial hardship as an effect of tuberculosis, but we need to determine, in fact in Australia, although we have good social protection, what are really the material costs of TB in our communities. And that's not just in straight out dollar terms, that's implications for education, housing and so on. Priority 3 is an area to address special needs of migrants and cross-border issues. So here we're recommending reviewing the appropriateness and feasibility of pre-migration latent tuberculosis screening. We currently have put a recommendation forward to the CDNA that help people coming to Australia on healthcare worker visas should be screened for latent tuberculosis before arriving. We recommend an evaluation of the current migrant screening program, both onshore and offshore, and look for opportunities for improvement. We think it's important to assess with migrant communities the cultural and linguistic acceptability of TB care that they're getting. And we also reiterate that it's important to support the government of Papua New Guinea for health system strengthening and to enable better prevention, detection and treatment of TB, and also to support initiatives aimed at TB control in that area between the two countries, the Torres Strait Protected Zone. Priority 4 is to undertake selective screening for active TB and latent TB, both in contacts and selected high-risk groups, and provide appropriate treatment. So in italics here, develop a national strategy on latent TB infection. A model for engaging primary care physicians. There is too many people with latent tuberculosis in any country, including our own, to be able to be solely treated by public TB clinics. So we need to broaden the number of latent tuberculosis savvy clinicians who can diagnose and treat this entity. It's important to evaluate the timeliness and completion of contact tracing and be able to pull in the jurisdictional data into a national data set so it can really see how well do we do on contact tracing. And as many know, we have issues in this country where common tuberculosis drugs and combination drugs and drugs for treating latent tuberculosis such as rifampicin are not available. And so we see that there is a role both for NTAC and others to lobby for better availability of these agents. Now, there has been some activity. Look, this plan is dated 16 to 20 and we're already in 2018, but at the end of last year we published a national position statement on the management of latent tuberculosis. David Stock from Tasmania was the lead author on that one. And with Ivan Bastian from South Australia as the lead author, we also at the end of last year published an updated position statement on the use of gamma interferon release assays. And we are looking closely at what Justin Denholm and his team are doing in Victoria with engaging primary care physicians, general practitioners for diagnosis and treatment of latent tuberculosis. Priority 5 is to optimise the prevention and care of drug-resistant TB. This takes a number of action areas to be considered. One is to look at the process currently of how drug-resistant TB is managed in our visa applicants and how they're followed up after they arrive in Australia. Streamline the registration of combination formulations. I've already mentioned that, but it's also relevant to drug-resistant TB. Complete a cohort review of Australian MDR TB cases. We get notifications, but how do we bring it all together? We believe we need to, and this is probably something that NTAC can take the lead on, is update national guidelines on prevention and care of MDR TB, including management of contacts. And in a broader sense, to see tuberculosis drug resistance in the context of antimicrobial resistance, AMR, and to align ourselves with both national and global initiatives in AMR prevention. And congratulations to Josh Francis, who with others, including several NTAC members, has recently had a cohort review of MDR cases published in the International Journal just in March of this year. So summarising over 240 MDR cases managed in Australia. We're getting through these priority action areas. Priority 6 is to ensure continued surveillance, program monitoring and evaluation, and case-based data management. And this is not only maintaining what we're doing in the production in a timely fashion, and probably more timely than we do for national surveillance reports, but also looking at whether the data we collect meets our strategic priorities, looking at ways of monitoring latent tuberculosis, and even the big question, should latent tuberculosis be a notifiable disease? Would that streamline some of the issues about collating data and following patients? Priority 7 is to invest in research and new tools, and this was the subject of my talk last year at CRE. It is largely statements that I think everyone can easily agree with, to identify and prioritise questions for scientific and operational research, looking at the implementation or development and implementation of new tools, not only physical new tools but also models of care and service delivery, trying to identify funding opportunities and facilitate collaborations between Australian researchers and researchers in our area. We're a resource-rich country, and one area where we can really contribute is in this field. And lastly, priority 8 is to support global TB prevention, care and control. You note that I haven't given examples for the last few slides because so many people, including many in this room, are doing a lot for not only research but also regional and global engagement. But we think it's important that individuals who work in an international context are supported to do so by their facilities and their governments, to better coordinate research efforts and collaborations between Australian groups and country and regional partners, to promote regional activities in TB control, including contributing to an advisory role. So we've had discussions about a TB concilium, similar to what is done in Europe, that might be implemented in Oceania to help with difficult and including drug-resistant cases. We also see it's important to develop opportunities and follow up on these opportunities for health system strengthening. And we also have mentioned the possibility of trying to encourage an environment where there can be some exchange of healthcare workers between our setting and higher burden TB settings and a bilateral exchange. So tuberculosis, we clearly think must remain on the political, technical research agenda in terms of our international and regional role. And then I'll come back to targets. So we had in NTAC big discussions about, do we set targets in our strategic plan? Is it unrealistic? Is it naive? Or is it bold and ambitious? We settled on putting targets because it's something to aim for, and I think we will have some success. But based on 2015 baseline of 5.3 per 100,000, we feel that in the whole population we would like to get to the pre-elimination levels of less than 1 per 100,000. On the way, that would mean reducing our rates by 2020 to 3.1, and of course that sounded a good idea in 2015. 2018, as you get closer, the target seems to drift further away. But one area we perhaps can have more success is to reduce the rate of TB in Indigenous Australians from the 2015 baseline of 4.8 per 100,000 down to, we're hoping, to 1.6 per 100,000, and then the pre-elimination levels by 2035. In fact, elimination levels by 2035. And as I mentioned, for the Australian-born but non-Indigenous population, we're already at that pre-elimination level, so we need to be getting to the elimination level by 2035, not 2050. See, some of the, I mentioned in the Indigenous population the cases are low, and some of that is driven by clusters and transmission. There's active transmission. So that's bad from a public health point of view, but it's also an area where we can intervene. So I think there may be some avenues to follow as we investigate clusters in at least a couple of our states. So the theme for World TB Day this year was Leaders for a TB-Free World. I hope that NTAC in some small ways is showing some leadership, but of course what needs to be done is very much in the room here. So thank you.
We've got some questions for Chris. Yes.
Hi, I'm Shiva. I have two questions actually. One is about TB in migrating population. Is it a very controversial issue that could be raised with the political representatives or not? Second, what about TB and comorbidities like TB and diabetes? Are there any specific strategies to address these problems?
Yeah, so second question first, then I'll forget the first one. But so different jurisdictions have different data sets. So there's a national data set for surveillance, and then everyone collects that data, and then there's some variation. So some jurisdictions might collect it regarding, for instance, diabetes as a comorbid factor, whereas others don't. And part of the study that I mentioned that Kerry Viney is the chief investigator is looking at things like additional risk factors, to be aware of. So it may be that we do need to broaden and look at to diabetes. So sometimes the issue is how the wording is related. So for instance, one of the things we collect is, have you ever worked in healthcare? And maybe that's just too broad. Maybe it's, have you worked in healthcare in the last 24 months and things like this. As far as the political impression, is that related to stigma? A question of stigma in being used as is it a politically charged thing that there's TB in migrants? Is that the question, or is it genuinely other politicians engaged in doing something about it?
Right. So my question is that if TB is an issue among the migrants, is this an issue that is not often talked among the political groups because it's controversial?
I think it's difficult for me to answer that because obviously in our environment we're talking about it all the time. I think that the number of, compared to say non-communicable disease, the disease burden is relatively small in the political sense, and so I would suggest that there are many politicians it's not on their radar, but there has been increasing awareness for several years now. There's been on World TB Day a breakfast with politicians in Canberra, and I think there's also some worldwide engagement of politicians. And if you're looking on that bigger scale, Australia will be participating in the high-level UN meeting in New York in September, which is again calling on all global politicians to show leadership to reduce TB. So I think it's patchy, but I think that there is growing momentum to see it as a politically important issue. Yes.
Hi, Chris. So I noticed the flyer for some kind of intervention targeting refugee health services. Is anybody doing anything similar in any of the states with services that serve a lot of international students? Is there an attempt to engage them regarding LTBI screening?
Well, part of, that's Victoria's stuff, so I can't,
Okay.
I don't have operational knowledge just to give them the credit for going down this path to engage primary care physicians. But that also includes students, and certainly Victoria have done some significant interventions aiming at awareness for students. One of the things is students are always afraid that if they get diagnosed with TB, they'll be deported, which they won't.
Yeah.
But so there's a lot of communication required there. There is, if you Google, student and TB in Australia, you'll go to an Australian government website, which takes you through both the symptom path and also referral system for, most of the time it says see your GP, but there is
Which they don't have.
there is a specific portal for students to go online to inquire about TB symptoms and signs in Australia. Yes.
Neil Herrick from the New South Wales TB program. One of the issues with engaging with the general practitioners is how is that going to be funded? Because a lot of the people that we might want the GPs to see won't have Medicare rights. So that's one of the obstructions, I think, to potentially going down the path. What's your thoughts?
I do get conflicting answers on what proportion have Medicare rights. People who are on bridging visas and released from detention and so forth have Medicare numbers. Students don't. And so they are required, of course, to compulsorily have health insurance to be able to study in Australia. So
But one of our central tenets is that there should be no cost.
Correct.
For that individual. So it has to be funded somehow.
Yeah.
There has to be some sort of recognition.
If a health insurance provider is covering the cost, then that would that would be okay. The essential thing is that there's no out-of-pocket cost. I mean, everything someone's got to pay for. Now, most of the time, we're, particularly in the health sector, happy for the Australian taxpayer to pay for a lot of stuff. But someone's got to pay. If it's an external insurance provider and there's no out-of-pocket costs, that's fine. But sometimes people run into problems. They've used their you know, they have other medical conditions, and then they get told, I know you've used up all your allocation or something like this. So I think the strategic plan does not necessarily provide answers for all scenarios, and I think this is an important thing, is really, you know, we've got a large number of temporary migrants, and how we look after them while they're in this country properly. It's better, you know, some countries in fact do send their migrants, temporary migrants, back to their country of origin if they have TB, and that's not something that we would ever contemplate, but we don't do too badly, but we could do better.
Greg, I think you had a question.
Yeah, thank you. One of the challenges in sort of the TB elimination space is engaging people who are not currently committed to the cause of TB elimination, and a number of populations come to mind, such as the Home Affairs Department, where there are other drivers of their decisions around screening other than just health, and also clinicians. You know, the general respiratory or infectious disease community, for example, may not be that engaged in actually actively screening for latent TB infection. So my question is, what do you think is the process to actually go and get much greater engagement in that as an objective? I know that NTAC is obviously committed, and so are those in the room, but how do we then take the next step and actually build a sort of a groundswell of support to change the thinking around LTBI?
Yeah, well, I think for a start, our regulators need to give us better tools more quickly, so that we can use existing things. Like, I mean, rifapentine, I think, is off patent, but we still don't have it in this country. So there's that, giving us better tools to do things. I think you can sell a treatment course to both patients and to the clinicians if it's a sort of a 3-monthly thing rather than sort of a 9-monthly thing. I think that we do have to think about how we fund, including for those that don't have Medicare funding, and even those that do. I mean, it's a long discussion before you go onto LTBI treatment. That's a long consultation. It should be funded. There's an item number for refugee health. There should be an item number that covers this thing. So we've got to convince those that can enable that this is worth doing, this is worth backing financially.
Can I just ask one question? On the Indigenous people, or Aboriginal people, it's interesting that it doesn't seem to be a problem on the scale in Australia, for example, that it is in Canada. And I'm just wondering at what level, and I'd be interested in the views of other people in the room as well about this, how much of a problem is tuberculosis for Aboriginal people, that there are a number of health problems to deal with in closing the gap, and my hunch is that tuberculosis is fairly low down on the priority list. And I just wonder, we need to think of this in a sort of, thinking of this in a holistic view about health and well-being of Aboriginal people. How active should we be? How much should we attempt to prioritise beyond what you said earlier, that there are outbreaks and we need to investigate those outbreaks? Should we be doing more, or should we not be doing more?
I mean, the key thing is that is meaningful engagement with Aboriginal and Torres Strait Islander communities. I mean, if the communities come and say, look, thanks for your concern, but we're more worried about smoking, diabetes and heart disease, well then that's maybe what their priorities are, and we need to respect that, unless, of course, we believe that the public health priorities override, which is the other side of the coin. So I think this is a challenge, and I think clearly it's a challenge because that's why the rates have not really altered for many years. They've just chugged along at that 6 to 7 times the non-Indigenous rate. And I guess we felt that if we're talking about heading towards pre-elimination or elimination, it's time to look at this. Whether it's successful or not, I don't know. But,
Anna, did you have a view about this?
Yeah, sure. I mean, I think it's probably Vicky Krause's view in the Northern Territory that it's perhaps lowish down on the agenda for a lot of remote living Aboriginal people. A project that we've got in a remote Aboriginal community, it was supposed to be about rheumatic heart disease, but their priorities for the community were nutrition, water, and how to deal deal with teenagers. So I think also there's very low health literacy. I think it's fair enough to say. So talking to community members about what do you think about TB would require education first about what is TB. I mean, we've had deaths from TB in Aboriginal people in the last couple of years, a couple. So obviously it is a concern, but yes, you have to put it in perspective, and I think it would have to go alongside a whole lot of other primordial sort of social determinants things as well, rather than a single disease focus.
Thanks.
Look, it's not, TB as we know is not seen in isolation, and usually, I mean, that decline in the Australian rates pre-rifampicin and pyrazinamide, that was about changing better health in the community. That's about better health services, health infrastructure, health-seeking behaviour, nutrition, a lot.
Okay, well, thank you very much, Chris.